healthcare principles and practice. Just want to remind you all that there is a link for CME for those of the faculty who are attending, and that is posted on the chat site. So you can take a look at that and then click on that to get CME credit. I also want to remind everyone, please make sure you've signed in the chat so we know who's attended and who has not. Today, we're very fortunate. We have two speakers. Our first speaker is Marvin Hall. He is a pediatric critical care doc and the associate medical director at Children's Hospital in Erlanger and an assistant professor of pediatrics here at the College of Medicine. Our second speaker is Kalra. Yav is also a pediatric critical care doc and is the medical director of the PICU and also for pediatric ECMO. So with that introduction, I will turn it over to them. They're going to be talking about patient safety and high reliability.
I just stop before we share screen.
Hello. We're working on sharing our screen here. So do we have the right slide up?
Yes.
Not the first slide yet. All right, we're going to go back to the first of the talk here. So first of all, next slide. So y'all don't have any financial disclosures. Do you have any? No financial disclosures. So just by way of introduction, so our plan today is that we're going to start off with a safety story. When you're talking about safety, sometimes it's helpful, I think, to begin with a story that kind of defines the problem. Then I'm going to give a few points about introduction to error in general. Then I'm going to turn it over to Dr. Kalra, my colleague here, to talk about kind of the fundamentals of high reliability and the characteristics that high reliability organizations share. Then if we have time at the end, Yelp's going to turn it back over to me, and then we're going to present just a couple of tools that you might use in your own practice to potentially improve reliability and improve safety for your patients. So I'm going to talk about baby M. So baby M was a 31-week prematurely born infant. Was delivered prematurely secondary to maternal chorioamnionitis. The delivery was otherwise uncomplicated. The patient was intubated in the delivery room secondary to respiratory distress and was brought to the neonatal intensive care unit. Now this was a level 3 neonatal ICU. Second-year resident was in attendance in the ICU. There was no attending immediately present, but the attending was just right next door in the offices adjacent to the unit. The resident placed a UAC and a UVC in order to optimally care for the patient, and then in the midst of the placement of those catheters, the patient developed a wide complex tachycardia. Thinking at first perhaps the catheter had been gone into the ventricular or even the atrial space, the catheter was withdrawn, the attending was called, resuscitation was begun, drew electrolytes, drew a blood culture, administered antibiotics. But despite this resuscitation, the pulse was lost and CPR was begun. A couple of minutes into the resuscitation, the initial electrolytes returned, and remarkably, the potassium was 8.3. The electrolytes were sent again, like, how could this happen? I don't understand this. Electrolytes were repeated, all fluids and syringes were removed from the bedside. Calcium, bicarbonate, glucose, insulin, all administered to the patient. CPR was continued. Well, lo and behold, the repeat electrolytes returned with a potassium of 13.2. CPR was continued, and ultimately the patient was declared dead in the neonatal ICU. A search was done of all the discard bins, and ultimately a vial of concentrated potassium was found in one of the trash cans. So how did this happen? Well, let's look at some of the causes. So the resident had been on duty for about 28 hours. As it turned out, this was the end of June. The new residents were coming, and she had volunteered to stay to cover for her colleagues while they attended a social event. The nurse who was present for this patient was a very accomplished neonatal ICU nurse. She had worked at another neonatal ICU for many years. She was a nursing instructor, but she was in the PRN pool at this institution, so she was somewhat unfamiliar with the environment and with the procedures here. And at this ICU, of course, concentrated potassium was not included in the pods, but it was available in the medication room. And as it turned out, potassium was immediately adjacent, in a bin immediately adjacent to the saline bottles. No one could recall when or if the potassium was brought into the room or for what reason. Markedly, the bottles were very similar to one another, that only the potassium vial had a red dot on the lid, but otherwise they were the same size and shape. Also notably, this kit for to place the UAC did not include pre-filled syringes, and ultimately it was determined that it was very likely that in placing the UAC and the UVC, that the flush solutions that were drawn up contained instead concentrated potassium. So how is it that we fail so often in our most fundamental obligation to our patients, and that is to do no harm? We're all highly trained. We work in a complex environment, but we're motivated, we're very careful, and of course, we're all emotionally devastated when some untoward event happens to a patient and our patients are harmed. So how does it happen? I would like to try to demonstrate this, first of all, by showing you a YouTube. Now, some of you may have seen this YouTube video before. If so, I would still encourage you to look at it really carefully. And there it is. So the goal is to count the number of times that the people in the white shirts pass the ball one to another. So we're going to see how reliable you are by asking you to count the number of times that the patients in the white shirts pass the ball. Full screen.
Sorry.
There you go, that's okay.
Hold on.
There you go. So I think we have it back. So okay, I think we're back here. Sorry for the confusion. So the answer to that question really is that humans are reliably fallible. Humans think really on three levels: automatic, rule-based, or knowledge-based. And each one of these levels of thinking leads to different kinds of errors. Automatic thinking leads to slips and lapses, and rule-based thinking leads to rule-based errors. And then knowledge-based thinking, of course, leads to knowledge-based errors. So I want to start in the upper left-hand corner with regard to skill-based or automatic thinking. Automatic thinking leads to slips and lapses. So a slip is when a more familiar routine takes over for a less familiar one. And a lapse is when you basically forget to do something. At least for me, one of my most frequent lapses is that I forget to sign off on my orders in Epic. I'm putting orders in and I fail to sign off on them, and I assume that those orders have been entered. That's a lapse. These are errors of execution. In other words, you intend to do something. The action is an appropriate one, but you carry it out in an inappropriate way or an incorrect way. Next are rule-based, and so rule-based is basically X. If X, then Y, and there are lots of rule-based rules in medicine, of course. If patients are hypovolemic, you administer intravenous fluids, right? That's a rule. But rules are prone to error based on applying the wrong rule or applying the rule at the wrong time or an appropriate way, or maybe the rule is no good in the first place. Perhaps the rule is bad. Then, and these are errors of planning. In other words, you intend to carry out an action. You carry out that action correctly, but the action was an inappropriate action. Next are knowledge-based rules. And knowledge-based rules are different in that they require synthetic thought. They are used for novel situations. They require conscious thought. And importantly, these are effortful. And so it's our usual impulse is to avoid operating in a knowledge-based performance way whenever we can. And that causes mistakes because it forces us, we're biased to apply the most recent rule or apply the most recent scenario. And we tend to ignore or minimize new or other important information. So also humans have inherent limitations. Humans are limited to perhaps 5 to 7 pieces of information in short-term memory. I know for the mini mental status exam, for example, we ask people to remember 3 different things. I don't know if you've ever tried to remember hold 7 independent pieces of information in short-term memory, but I can't do it. Of course, stress affects our ability and error rates increase. We develop tunnel vision under stress. Fatigue influences our performance as well. In fact, you may be aware that 24 hours of continuous attention is equivalent to approximately about 0.1 blood alcohol level. And then, of course, we're limited in our ability to multitask, i.e. with cell phones and driving. This is my favorite cartoon of situational awareness, and it introduces the concept of aviation as an analogy for medicine. So can we eliminate error? I think most people would agree that no, we're unable to eliminate error. But if not, then what is an acceptable rate? What's the rate that we can try to achieve of significant error? Well, one way to look at this is, keep going, is maybe if we apply this question to the airline industry. So if we say that a significant error in the airline industry results in a plane crash, let's just do a little math. So there are, in 2012, probably a little fewer now in the COVID era, but there are about 868,000 scheduled U.S. commercial flights per month in the United States. These exclude small jets and cargo planes. Next. So if we reliably prevent error in aviation, you can see that even if we are at the 0.0001% error rate, that still results in 8.7 plane crashes per month. And even if we're 0.00001% accurate, that still corresponds to approximately 10 to 11 per year, or 1 plane crash per month. So the point is that we have to achieve very high levels of reliability in order to protect our patients. But of course, these are not all independent actions that we're talking about. We work in a realm of complex systems. And this is a slide that just looks at how many steps are involved in accomplishing a task, and if the probability of success for each one of those steps, how often it results in a positive outcome without error. So it's been estimated, for example, that prescribing, dispensing, and administering one medication in a hospital environment includes approximately 40 separate distinct steps, each one of those with its own risk of error. And so you can see that even if you carry out each one of those steps with a 99.9% reliability, 4 times out of 100, the wrong patient will get the wrong medicine, or at the wrong time, or at the wrong dose. So we should aim for, and we require, a very high degree of reliability. So how often do we make errors? Well, this has been studied before, and errors of omission in a complex environment occur approximately 1 out of 100 times. This is, for example, the nurse forgetting to turn on an infusion pump, or me forgetting to sign off on my errors, on my orders that I've entered into Epic. Errors of commission occur approximately 3 out of 1,000 times. This is, for example, misreading a label or turning on the wrong infusion pump at the bedside. And notably, severe stress increases this error rate by about 25%. Next. So let's look at hospitals and the error rates in hospitals. So you can see that approximately 2 to 3% in these 2 studies of patients admitted to a hospital had some sort of adverse event. And you can see the percentage of those varied between 6 and 13% of those adverse events resulted in deaths. This has been termed the $17 billion problem in healthcare. Next. I realized that my references were getting somewhat dated, so when I was prepared for this, I looked for a more recent reference, and so this is it. Surely we've gotten better in the interim. Well, this was the largest study of errors, hospital errors, that I could find. And you can see that in this study published in 2018, and including approximately 27 countries, about 10% of admitted patients had some sort of an adverse event. Most prevalent were operative or surgical related events, and second were medication related events. About half of those were preventable, and with regards to severity, 21% of those resulted in moderate impairment, whereas 7% resulted in permanent disability, and another 7% in death. So if we here at Erlanger were average, this would mean that one would predict about 150 patients a year would die here at Erlanger secondary to adverse events that were preventable. and another 150 patients would suffer permanent disability. Next. And so with that, I'm going to turn this over to Dr. Kalra to talk about high reliability organizations.
Perfect. Thank you, Dr. Hall. So I think I was set up well by Dr. Hall by giving that perfect example of how a standard procedure of placing umbilical lines in the neonatal ICU can sometimes have untoward outcomes, which may not directly even be related to placement of a line, but just highlights the complexity of systems and that we live in and operate in, and sometimes some of the basic processes can lead to adverse outcomes. So with that, we talked about high reliability. I was first introduced to the concept of high reliability a few years ago, and I think that since then, I think it is something that I always try to remind myself of and practice using the principles of high reliability in my daily functioning. I have to admit that it's something that obviously is not intuitive to us. It's not taught to us, at least in medical school. At least was not part of my curriculum. And so I think it is something that I had to learn after the fact as an attending level, but I cannot tell you how important it has been on my daily day-to-day workflow. So talking about high reliability, what does it mean? I think the most landmark report that I think a lot of you are aware of that came out of Institute of Medicine in 2001 to Error is Human talked about the amount of errors that were happening in the field of medicine that were much more than most people realize, which basically set a few of the pioneers in the medical in the business on this journey to basically make quality and a part of the medical culture. So high reliability was a term that was adopted from the aviation industry, from the nuclear power industries that are considered to be highly reliable, where they're on the outside, there is no room for error, and if there is an error that occurs, it can have catastrophic outcomes. So if you adopt some of the same principles, really high reliability comes down to a state of collective mindfulness. Again, understanding that we work in complex systems. And so having the mindfulness that things can go wrong and that humans make errors, having that level of situational awareness is important to basically mitigate some of those risks. Again, if you look at the other points I've written down, again, it's a concept of achieving high degree of safety and reliability because we know that we work in complex and nuanced environments. The high reliability does come down to the number of defects per opportunity for that defect. So obviously lower that number, the more highly reliable we are. And it goes hand in hand with having a culture of safety. Again, understanding that we will make errors, things will happen. So having that culture of safety where everybody feels comfortable raising a level of concern if they feel that standard work is not followed or something just doesn't feel right. So people are empowered to basically speak up and interrupt in case they feel like something could potentially go wrong. And so culture of safety is something that's a culture change for most of the medical organizations, and I think it's something that it's a constant effort. So like I mentioned, the first report that came out that started a lot of people on this journey came out in the year 2000, 2001, where the medical industry then realized the need for high reliability. People realized that there were recurrent incidences of preventable harm, like Dr. Hall just highlighted. 51% of the adverse events that were highlighted in that paper are preventable. There's obviously some level of fatigue around this, and so I think that having some level of a collective state of mind of minimizing harm is important. We all know that when we work in medicine, we try to achieve for success in the area that we work in, and that has repeatedly resulted in silos, even within our work environment, that we try to achieve for success in what we are doing, but at the same time, to achieve a state of high reliability, we have to understand how systems work and how we all interact with each other and how that can increase the level of harm if there's not appropriate communication or standard work that's created. Like I said, everything does come down to a level of communication between systems. And then also having technology now is a part of it. And I think something that I think Dr. Hall kind of talked a little bit about is how technology has now introduced a new level of potential harm that needs to be mitigated to make sure that we are all facile with the limitations of technology that we use on a day-to-day basis. And that has led to emergence of QM methodologies. I think we all know we have quality experts in most medical systems, people who are facile with Lean or Six Sigma, but we also understand the limitations of using the Lean and Six Sigma systems in medicine because we deal with human beings and not machines. So, like I mentioned, what are the challenges of achieving a state of high reliability? I think I have to say that it is a constant effort. It is something that we all have to remind each other, and at some point it becomes the fabric of the institution. But some of the common challenges that we face is, like I think has been previously mentioned, we work in a very complex environment. I think whether you look at surgical environment, anesthesia, ICUs, a regular inpatient, outpatient workflow, it is a very complex workflow. Even dispensing a medicine from pharmacy is a complex workflow, much more than I think all of us kind of recognize, because we think this is how it is done, and we don't pay attention to the amount of systems that go into play to be able to dispense a medicine. There's obviously, traditionally, medicine has always been hierarchical. We always defer to experience than to expertise. And so with high reliability, this is an important factor, which I will highlight a little bit later, where we should start to change experience. There is no question that experience is important, particularly when it comes to complex medical situations. But we also have to pay attention to expertise that may not always align with experience. In this communication, and when we have this complex communication network with complex patients or complex processes, we have a lot of decision makers. We all feel really high degree of accountability where we don't want to make errors. That's the fundamental of our field, where do no harm. But that sometimes can come in the way of adopting a highly reliable institution, particularly when we are interacting between different services and have to have a high level of communication. We all work with compressed time constraints. I don't need to expand on that. We obviously have a lot of turnover. We all know at every work level, whether it is frontline workers, administrative worker people, physicians, advanced practice providers, there's a level of turnover that I think makes it difficult to sustain high reliability. And then at the end of it, I think, like I mentioned before, at the end of the day, we are taking care of patients, and no two patients are alike. And this is not similar to working with machines. And so applying Lean and Six Sigma can be challenging in healthcare. So having said all of that, I think high reliability has been adopted by a lot of leading organizations and healthcare organizations throughout the world. So what makes high reliability successful? Number one, we have to engage at each level, whether it is a frontline provider, whether it is a C-suite, whether it is a group of physicians or anybody. We have to engage in it together. We have to educate each other and maintain a level of humility, understanding that we are here to learn from each other and defer to expertise. And then to constantly execute and evaluate, just like a PDSA cycle where we say what is working, what is not working, and that's what makes institutions stronger. Again, I cannot overemphasize that high reliability cannot be successful if there's not buy-in from everybody, whether it is team leaders, frontline staff, C-suite, senior leaders. Everyone has to buy into the idea of high reliability. And it does, and execution of high reliability does involve standard work. Cannot overemphasize that we all require standard work with some necessary variance, because we are dealing with human beings and not machines. So some degree of variation is important between providers, but when we come down to anecdotal experiences or what is comfortable to us between providers, between frontline workers, is when we increase the level of, or at least increase the potential for harm. It's important to have independent checks in the system. And most importantly, anytime there's a mistake that happens, rather than having a punitive culture where we blame and oversimplify things to say it is somebody's fault, to learn from those mistakes and see how can we make our system stronger. To me, that is probably the most important thing I've learned in high reliability, is to move the emphasis from people to systems. So key pillars include leadership, having stable and sustained leadership, to have a culture of safety where everyone is empowered to speak up and to foster that culture of safety, and then to have a robust process improvement using the tools from Six Sigma or Lean, whichever way the institution is aligned, is to use some of those tools to basically do a thorough analysis of process improvement and do it on a constant basis. So with that, I'll talk about the 5 principles of high reliability. I think what I would love to take away from this, if you can remember some of these elements, I don't always remember them, but I think if it becomes a part of culture and it's something that's talked about in your work area, I think it does become a fabric of your work area, and we are currently trying to do that in our unit. So the number 1 is preoccupation with failure. I think a lot of you, I think this is something that maybe is a more intuitive, because part of our work and part of what we have trained to do is to minimize harm. And so when we do any complex procedure or any sort of take care of a complex patient, I think there's something that's always telling us what can go wrong. And I think that that's a good intuition. It's a sixth sense. It's something that tells you, what can go wrong with that patient. And I think thinking about those things and having a clear line of communication with your team about preoccupation with failure, about whether it is that process, whether it is taking care of that patient, to understand what are the complexities of that procedure, of that patient care, of medication, whatever that may be, whatever you have done for that patient, understanding what are the complexities that have been involved in that, and how we can communicate that with the rest of the team so that people can watch for that and avoid and basically be able to mitigate harm. So it's basically emphasizes the Swiss cheese model of failure, where I think they're not proper checks built into the system. So I think if one mistake is done, obviously it percolates down without being checked. And this also encourages error reporting. So we have our ESEF system at Erlanger. Most institutions have their own error reporting systems. And so encouraging people at every level to report those things. Again, very important to do that, because this is not punitive, but this basically, in an ideal environment, should make our system stronger. And to report near miss events or sentinel events. Avoiding complacency. So things are going well, or certain processes working well in our work area, to not become complacent, because understanding the complexity of the systems we work today. And I think, something that the minute we take away vigilance from that process, it can lead to mistakes. And then to avoid temptation to reduce margins of safety. Again, always paying proper attention to what is standard work. That sort of segues into the second principle, which is reluctance to simplify. Again, I think that when we are working in complex environments and that involves several teams, I think to me, I think it is somewhat intuitive to us to simplify those things for those teams, to what to watch for, what to do. But I think this is exactly what high reliability talks about, is not to oversimplify systems, because we all now understand we work in nuanced systems. People bring a different level of expertise. So when we take care of processes or patients that involve multiple teams, multiple environments, is to not simplify those things, and in fact embrace them and understand the complexity with which we work today, so that if an error happens, we can actually do a deep dive and do a root cause analysis to understand where the process broke down, because I think all these processes are interconnected, and so a break in one of the process can have downstream effects. And so just understand in your work area that we are working with complex environment, complex systems that involves a lot of people, a lot of technology, and not to oversimplify things, and embrace the complexity that comes with our workflow today. So again, we assume that most situations are complex and unstable, and things can go wrong. And not to try oversimplify things when we are understanding that our environment today is inherently complex. Sensitivity to operations. So what does that mean? I think understanding that the real work gets done at the frontline level. I think there are two elements of high reliability that talk about that, one that I'll get to in a minute. But understanding where when the real work is done, we understand what the frontline staff members have to do to accomplish that task. And if an error happens, how do we understand that workflow and can make it better to mitigate that harm? So when we are working, if we are not at frontline, I think if an error happens, I think high reliability encourages us to basically understand that workflow at a frontline level, because unless we take the time to do that, I think it is important. It is hard to mitigate that level of harm. It also, sensitivity to operations also talks about situational awareness. Again, taking care of a complex process, taking care of a complex patient, understanding that in that moment, all the things that can go wrong, and having a clear plan of communication between teams to anticipate that harm and to think of some strategies to mitigate harm. And then continuous adaptation. Again, we are working with human beings. Things change, people change, there's a lot of turnover. And so how do we constantly adapt to be able to keep that process intact and take some of the human factor out of it? And then pay attention to work relationships. I think we all know that the more, I think if there's a culture of intimidation or fear, that I think frontline workers are often afraid to speak up their concerns because they don't feel comfortable talking about it. So changing that culture of safety and having that professional interactions between services with mutual respect, that people feel empowered to speak up. And then commitment to resilience, because understanding no system is perfect, whether it is Erlanger or it is Harvard or any other systems we work in. I think all systems have problems, and I think that high reliability talks about an intrinsic ability of an organization to rebound and to attain a dynamically stable state even after a major mishap has occurred. And so in times of stress, in times of mishaps, how do we still sustain some of these, our standard work and some of these processes, even though some major adverse event has occurred? And how do we bounce people back and to sustain that level of dynamic stability? Continue to work on error mitigation and continuous improvements, and then put a lot of time and effort into training people and personnel to what standard work looks like. And then lastly, I would talk about deference to expertise. Again, this is something that is a culture shift at the organization level, where we de-emphasize experience to some degree and emphasize expertise. So just because somebody has experience in the area or hierarchically, from a hierarchy standpoint, they sit a little bit higher than the frontline worker, does not necessarily mean that they know more about that process than the person at the front line. And so cultivating that culture of mutual respect, where we basically defer to expertise, that it may be a frontline worker, it may be somebody at an administrative level, and getting their opinion to make the process stronger, and to move away from rigid hierarchies, because that leads to higher error rate. Allowing decision to be at the front line, and basically push down decision making more at the front line where the real expertise lies. And then again, it cannot, like I've talked about in my whole talk, is that experience does not always equal expertise, and to make a cultural shift towards expertise rather than defaulting to experience at all times. So developing a framework of high reliability is not easy and has to be done on a constant basis. I think it involves people at a C-suite, at the senior administrative level, at a frontline level, at team leaders, and having good protocols in place that allow some level of variation between providers, between patients, but by and large stick to standard work. And then creating a level of culture where a culture of safety where frontline staff is comfortable voicing their concerns. And on the other side, once you have sort of created that culture, or you're in the process of that culture, at the same time measuring some of the outcomes, what is current state, what is ideal state, and what are the barriers to get there. You always utilizing evidence-based interventions rather than anecdotal, and then constantly assessing evidence because it is changing in our world. and looking at a constant review of errors. So when we do error reporting for a problem, what is our standard work? Can we improve that standard work? And where did the process break down so we can improve that? And then again, emphasizing culture of safety on a day-to-day basis so that people feel empowered to speak up. That's basically the framework that I was talking about. And with that, I'm gonna turn it back over to Dr. Hall. I think we still have a little bit more time.
So I imagine for some of you, this is maybe your concept of safety in a hospital environment. We talk a lot about central lines and CLABSIs preventing catheter-related central line-related bloodstream infections. We talk about rapid response teams, rescuing the patients before the event of an arrest, surgical site infections, appropriate antibiotic administration, hand hygiene, influenza immunizations, infection control, et cetera. All of those things, those processes that occur within an inpatient environment, they are incredibly important for patient safety. All of those things that we talk about and that conceptually perhaps is your vision of safety in a hospital, they're exceptionally important. They're just not enough. Because all those things occur within a culture. Dr. Kalra talked about culture and the culture of high reliability. And so in a highly reliable culture, the culture is one that breaks down hierarchies, that encourages collaboration, that not just welcomes questioning, but celebrates questioning. Within a high reliability system, the processes are important, but the culture is important as well. And we're really talking about a culture shift toward high reliability. So in that regard, I thought I might leave you with just a couple of tools, tricks, if you will. I'm remembering I left out something on the prior slide, so I'm actually going to go back to it. So with regard to culture, it just occurred to me that, and I think this is important to say that this is a culture, we'd like to cultivate a culture with that, where our antennas are constantly up, where we're looking for that next opportunity for failure. And importantly, when things seem to be going well, what do? Our antenna go up further. We look harder. What is it that we're missing? It's that preoccupation with failure that we were just talking about. So Wyckoff Sutcliffe would say, that when things are going well, we are operating in a complex environment. Errors are likely to occur. What's happening now? Are people discouraged from reporting things? What could we be missing? Where are the signals that we should be seeing? We need to look harder. Our antennas go up further. So in that regard, I want to encourage you to utilize a couple of tools. Now, these are simple tools. Maybe it's not even important that you remember the mnemonics, but I wanted to leave you with something that you can use today to improve reliability in your own practice and where you are. So the first tool is one that we've called STAR. Stop, Think, Act, Review. Again, it's not even important that you remember the mnemonic, but it is important that you remember the principle. So this is something that you can do all by yourself. You don't have to say anything out loud, and it takes 2 seconds. This is just a mental timeout. So before proceeding with a procedure or some administration or something, take 2 seconds to stop, think, act, and review. So stop, just pause, focus your attention on the task at hand, think, what are you going to be doing, plan your actions. What happens if it doesn't go like you're expecting it to go? What are your mitigating strategies, for example? What are your rescue strategies necessary for the patient? Act, carry out the planned task, and then think about it again, review it. Did things go as you expected to? Why not? And if they didn't, what do you need to do to mitigate that situation? Stop, think, act, review. Takes 2 seconds. I left this in here just because I thought it was kind of funny. So it only takes a few seconds, and this has been shown to decrease the rate of making an error by 10 times. By a factor of 10, you can reduce your risk of making an error before a procedure. Next is ARC. So this is, the first one was internal, this one is external. So this is how you can help your colleagues, your coworkers perhaps, prevent an error and help them not to harm a patient. So this is the ARC. And again, it's very simple. First of all, you ask a question. Well, you get that little pinch. Maybe something's not quite right here. I'm worried about this. I'm wondering if this is the right thing to do. This is when you apply the tool of ARC. First of all, you ask a question. Did you really mean to order 100 units of insulin? Ask a question. And oftentimes, your concern is taken care of at that very level. Next, if it's not resolved, then request. If a team member doesn't modify their plan, ask for a change. Request a change. That's the R. Request a change. Would you like to instead administer 10 units of insulin? Request a change. Again, if it's not resolved, then escalating your next voice of concern. And we have to remember that when somebody says, I have a concern, or I'm concerned about that, in a highly reliable organization, that's a stop the assembly line kind of a phrase. We should all pause, stop what we're doing, and resolve that at that level. That's a safety phrase. I have a concern. If they still don't notify the blank, then the next step up in escalation is to notify the chain of command. Perhaps we should call the pharmacy to verify this dose of insulin. Perhaps we call the attendant to make sure that we're all on the same page and make sure that we've resolved this concern. Again, oftentimes the concern is resolved at that very first step. It's important that we first ask the question. We don't remain silent. So that's all that I had today, unless Dr. Kalra wants to add something. Again, I just thought this was kind of funny. Somebody has to do something. It's just incredibly pathetic that it has to be us. So with that, I don't know, how do we pause for questions?
Yeah, at this point, we can take questions. People can either raise their hand or they can post them on chat. So we can look at those questions.
Chat. That just be.
So while we're waiting for some questions, you both presented a lot of material today. I guess my question would be, what are the 3 things that you think the residents should really take away from this talk? What are the 3 most important things as we move to high reliability?
So I'll yield to Yav here in just a second, but the things that first occurred to me is 2. I have 2 that I thought of. One is it's up to you. You know, this is important for all of us to adopt the principles of high reliability. It's up to all of us to try to prevent harm to our patients. And certainly in an institution like this where resident staff and medical students are so integral to the care delivery here, certainly the residents form a fundamental and essential part of that chain, of that process to prevent harm to patients. That's number 1. And number 2 for me is, I would appreciate if you'd remember a tool, you know, one of the 2 tools that we talked about as just examples, because those in a very concrete way have the potential today to help prevent us from harming a patient. Dr. Kalra.
So Dr. Cord, thanks a lot. So I think if I was a resident today, I wish we had the same teaching that you have instituted here. So first of all, I need to thank you for bringing that culture of quality here a long time ago, for Dr. Hall to have carried that. I think that for me, going through the system and learning from my own mistakes and other mistakes being around me, I feel that we have to maintain a level of humility and understand that all of us will make mistakes. I think that that's going to happen. And to whatever environment the residents go to, whether they're outpatient or inpatient, to really change that culture of safety where we truly are non-punitive and focus on processes to basically make the system stronger, because we're all moving into more complex systems with more technology integration, and some of them are predictable and some of them are unpredictable harm that potentially could come our way. And to always have that level of vigilance, and then really maintain some level of humility that we will all make errors and have a non-punitive environment. The second one I would say is communication. I think that, we are all I still feel medicine is still very siloed. I think we are all very occupied with our own workflow and what we do in each area. And the reality is we are really constantly interacting with each other. And I can't overemphasize how much I think, to me, communication has become really, really important. So those are I think the two things that I would probably say is communication, and then humility, because I think we will make errors, and having some level of mutual respect for true expertise rather than always deferring to experience, which I think is still, medicine I still think is very hierarchical, and experience is very important, but I do feel like we need to truly defer to expertise and when an error occurs and to mitigate harm.
So I'm going to add one more thing after just thinking about it here for a second, and that is one other thing to take away is a sense of urgency. We're all preoccupied in our own practices, in our own private lives, but I would encourage you to leave this with a sense of urgency. I was just awestruck when I went through the calculation that resulted in my estimate that in Erlanger Health System this year, 150 people, if we're average, and that data was correct, 150 people would die as a result of preventable medical error, and another 150 people will suffer permanent disability as a result of preventable medical error. That's striking.
And I think that's a great message for everybody to take home, is that this is real, this does affect patients, this does affect families, and that we are the ones who are causing that harm. Yav, I don't know if you're still there, but I think that you hit three of the things that I certainly would stress. And from a very practical standpoint, as far as learning from our mistakes, being humble about it and saying we do make mistakes, but also learning from those. And from a practical, actionable standpoint, that's making sure that we put things into eSafe. That's the only way we're going to learn, is if we put them into eSafe. And then the second part of that is that we follow up when we put something into eSafe, and then it doesn't disappear into a black hole. Those are critical things, but we do have to report if there has been an error.
I think that's right, Dr. Court, and certainly that's, it doesn't come out as one of the essential components of high reliability, but certainly in a highly reliable organization, all of those reports, the near misses those are golden kernels that should be taken full advantage of because, again, hopefully events occur on relatively infrequently, but these near misses occur much more frequently, and we have something to learn from each one of those.
And the final thing I would say is just also, Dr. Kalra talked about communication. And the one place where residents have an opportunity and the potential to help prevent errors is when they do sign out and transfer of care. And it's not just residents, also attendings, but making sure that you're anticipating what can go wrong in that sign out, in that transfer of care, and thinking about that before that event occurs so you really can anticipate it and hopefully prevent it. Any other questions, comments? Dr. Hall, any last comments?
Well, just take away with you that sense of urgency today. Go out and in your practice, utilize tools and with that focus on the potential for error, try to prevent harm to our patients today.
Thank you both very much. This has been very helpful, very educational, but also very practical. And people need to think about the tools they can use and how the things that they do on a regular basis can help prevent injury and harm to our patients. So thank you both very much. What an excellent, excellent program. We appreciate it. Thank you.
Thank you,
Everybody have a good day and stay safe.